Are you trying to get Karen Harkin Zoom meeting? Yes, 9. Do you want to go and there's another meeting happening there too? Can't get my volume up.
That we are having problems.
Good morning, everyone. Again, it's so good to see your beautiful faces again, and welcome to Stride Room number 5 now. We have 2 more to go after this, so we're well over halfway now. And I'm very heartened to see the level of participation that we've already had so far, and I hope everyone is enjoying the sessions as much as I am. And I must say, I'm really looking forward to today. I'm not really sure what's in store, but I know there's a creative team behind what's happening with Megan Williams, Auntie Linny, Nikki Percival, Renee Blackman, Michelle Dixon, and Katie Conti, all the way from the US. So very much an international team today. I think we're going to be taken on a journey, and I know that we'll be focusing on strengthening health promotion and chronic disease prevention, which is Stride's research program 4. So I know it's going to be an action-packed day too. So without wasting too much time of the team's time, I'm going to hand over to Auntie Linny to give an acknowledgement to country.
Morning, everyone. Thanks very much, Veronica, for that. Yeah, it's going to be a pretty action-packed day and a bit of a journey for sure. Firstly, acknowledgement to welcome you all to this beautiful Larrakia country, our dry season, and you'd be all jealous because you're all wrapped up in your woolies and that, and we're just enjoying you know, the beautiful weather here. But firstly, I'd like to acknowledge you all and all the country and places that you're all sitting on here today, and on those Indigenous nations, place and country, to pay respects to our elders, our leaders, past and present, and to all our emerging young researchers in the CQI space and beyond. But just a little bit, just to talk about Larrakia country. It is a beautiful place of land and inland, sea and inland country that spans all the way from Cox Peninsula, all the way round to Gunpoint, and then down to Adelaide River. And it's an important place for our neighbouring places like Tiwi and Walgett, and that came to Larrakia and for trade and for ceremonies, and there are a lot of songline connections to this place. And so it is really, really important to acknowledge the the context and the boundaries to which that is. And it's also had a very long-standing land title claim in the Kenby. And so it's an important story to tell. And I want to take this opportunity to pay acknowledgement to a very senior elder that we've worked for many years, Aunty Lorna Pijo, who recently turned 90 years of age and is now in our aged care home, but who married into Larrakia family and also the founder of the Strong Woman, Strong Baby, Strong Culture program. And I want to acknowledge her, who has been a wealth of wisdom and support to all of us in our work. Additionally, to know that there's a beautiful song called The Arapura Pearl, which Alison Mills talks about this place, and that's just a lovely song. But more importantly now, in the CQI space, it's the birth of problems here, but to acknowledge Professor Ross Bailey here, because this is where ABCD-CQI all began. So thank you very much, Veronica.
Hi, it's Megan Williams here. I'll wave so you can see me. I'm coming to you from the land of the Gadigal people, on whose land I work and live and raise my family. And on behalf of our Program 4 area, I'd like to acknowledge the broader CRE Stride family and all of the many partners that are part of this project. And you can see just some on the slide. And I'd also like to thank all of you and acknowledge much work that many of you have already contributed. And thanks for joining us today. So we'll all introduce ourselves. Michelle, could we start with you?
Sure. Hi, everybody. I'm Michelle Dixon. I'm a Darkinjung Narago woman, and I live, work and play on Gadigal land. I'd like to thank Aunty Linny for those beautiful words this morning, and echo the welcome to everybody to this particular workshop. I work at the University of Sydney in Aboriginal and Torres Strait Islander health promotion. I've been working there for 10 years, but I've been working more broadly in prevention and health promotion for 26 years. I'm really passionate about capacity building, and my specific focus is really on workforce development and how we can support our health promotion practitioners to really share the beautiful and wonderful work that's happening around our country. And so I hope to be contributing to this stream in that space. That photo is taken of me all wrapped up in a puffy jacket that I thought I would never own one of those, to be honest. But I was very, very lucky before the COVID lockdown to spend a bit of time working with some First Nations colleagues over in Canada. So they captured a photo of me all wrapped up. Usually I really don't. I'm running hot, not cold, but it was very cold over there in Canada. So lovely to have you all join our space. Thanks, Meg.
And how about you, Nikki?
Hi, everybody. I'm Nikki Percival. I'm coming to you from Gadigal land and pay my respects, past and present and future emerging Indigenous and Aboriginal and Torres Strait Islander people who join us. I'm a researcher at the University of Technology, Sydney. Before I became a researcher, I guess I spent about 15 years as a health promotion practitioner in Queensland, and then in senior policy roles in the Northern Territory. I'm a CRE Stride Chief Investigator, and I have the wonderful privilege and I'm honoured to be working alongside my deadly crew here as a co-lead for the theme and Program 4. This photo was taken of me at the finish line at Mount Charleston Marathon in just outside Las Vegas in the United States. It says a few things about me. I don't know whether people can see, but the label on my shirt says that I'm a Sydney Strider. So I thought that was a pretty coincidental kind of shirt in relation to the CRE Stride. I love to travel and have been known to run a couple of marathons while on overseas holidays, so many people will know that. I also enjoy a good challenge. And while you can't see them in this photo, anyone who knows me knows how I have a pretty amazing collection of shoes, not just sneakers. And I always find that running is a really great analogy to CQI because it's a journey of continuous improvement. And the more I run, the more I learn. There's lots of structured training and collecting and reviewing my performance data, and takes a lot of persistence and perseverance, and there's a team of supporters and believers, and I'm really excited that I get to meet people from all corners of the globe and share stories about what worked in the run, what didn't, and always the plans for the next event. So thanks very much, and lovely to join you all here today.
Thanks. Well, I'll roll in there, all puns intended. It's Megan Williams here. Most people call me Meg. I'm Wiradjuri through my dad's family and have English and Irish heritage as well. I try and put a roller skating analogy into anything that I do. I'm on day 144 of my daily roller skating, and these are my beautiful indoor skates. I feel like I work really hard, and I'm sure many of you do, and at the beginning of the year decided to set myself a minimum of 15 minutes of fun a day, because that fun is instrumental to health, as you know, you've all probably told many people. So I thought that I would walk the talk or roll the talk. And I had about 10 years in health promotion in the early to mid 90s, mainly in needle and syringe programs. And my boss sent me on a research training course because he thought that I was probably too shy to be going to Gold Coast nightclubs with Conjo Man. And he was spot on. They'd never met as big a nerd as me. And so it's been my absolute privilege really to work alongside service providers and do evaluations. I love the idea of more Aboriginal people in research. And so that's really why I'm sticking with CRE Stride. So yeah, thanks. Hope you enjoy the journey today. We go to you, Renee.
Yeah, g'day everyone. I'm Renee Blackman. I'm a Gubbi Gubbi woman living in beautiful Kalkadoon country. So Gubbi Gubbi is on the Sunshine Coast. I had to learn really, really quickly living in and working in Kalkadoon country and many of those Gulf community areas not to dip my toe in salt water. There's some pretty big lizards out here. And I miss that. I do miss the salt water because that's exactly what gives me peace, and that's exactly where I find myself, and also pay acknowledgement to my old people, because you learn a lot from being around salt water, and believe me, you learn a lot from being around this salt water. Look, I come to this work in CRE Stride as a service provider. I am currently the CEO of Gidgee Healing. I have a passion for CQI. Because I've been a health provider as an Aboriginal health worker and a nurse for the last 25 plus years. I really, really believe that everyone in this country is entitled to quality healthcare, including our communities, and CQI and health promotion are a huge part of that. One of the reasons why I'm very interested in this particular project and actually being part of this fantastic team, and it's a great team to be around because they are very patient with me in terms of me always bringing them back to, hang on guys, I don't know where you're at, because I'm very much a beginner at the academic space. I've always felt that us over here in service provider land really need to create more connection with what's going on in the discourse inside at universities and all of not the CQI, but the evidence-based practice that's being developed inside of an academic institution that really needs to flow into industry, so we can both help each other, I believe, and that's why I really enjoy being on projects like this, so that we can find that middle ground and we can find that conduit that actually makes that possible. So I'm looking forward to the journey. I'm looking forward to seeing what projects pop up, not just in this particular stream, but also in other streams. And I've enjoyed every Zoom meeting that I've been on related to all the groups, and looking forward to the others that are remaining. But this picture here is myself and my youngest daughter, Steph, doing what we love to do when she's home for holidays, because she's at boarding school, taking a beautiful afternoon stroll in Kalkadoon country. I've got 3 children. She's my youngest, but this is my walker. This is my little partner who never says no to when mum turns around and goes, "Come on, Steph, come for a walk because I'm frightened of them dogs." So she comes. But yeah, that's, as you can see, she's quite respectful. She has headphones in most of the time as a teenager, but always leaves that one free on my side so we can have a yarn. Thank you.
Absolutely gorgeous. Thank you. Katie, will you tell us about you and your special family member in the photo?
Yeah, hi everyone. So I'm Kathleen, or Katie, call me Katie Conti. And I joined CRE IQI and Stride when I lived in Australia. But currently I'm talking to you from Abenaki country, which is in Vermont on the east coast of the United States, where I currently am living. But I'm also working as an assistant professor at DePaul University, which is in Chicago. So I'm a bit all over the place. My background is in health promotion. Before I came to Australia, I coordinated health promotion programs and did action research projects, mostly with American Indian tribes out on the west coast of America. And I'm part of Stride, this program, but also part of the systems thinking work that Stride aims to do. So the picture that I have, this isn't a family member, it's just a friend, but a very good friend. It's a picture taken a few years ago. One of the nice things about being back in the States is I've had a chance to reconnect with my love of riding. It's a bit hard to take a horse to Australia and back again, so that's not something I kept up when I was there. But I'd like to draw an analogy to CQI, like Nick, because riding is a constant conversation. It's a participatory activity. It's constantly adapting to every little thing that comes up, constantly revisiting, rethinking, things that we didn't think about yesterday all of a sudden become big problems today, even though we've walked past it 50 times and never noticed it before. So I like that idea that riding is also like CQI. It makes you stay on your toes and makes sure that you're listening and not falling asleep behind the wheel.
Wonderful. Well, thanks. And yeah, we hope that you'll get to know us a little bit so that you feel that you can, you know, approach us after this and also join in any of the work, and certainly create that opportunity to hear about your work. So today we'll give you an intro to what we've committed to doing on health promotion within CRE Stride. We want to introduce the concept of community of practice, and we've got some questions that go along with that. Then we'll get on the bus with Mad Bastards. It's not technically swearing, it's the name of a film. And on that, we're going to hear about the journey so far with health promotion and continuous quality improvement. And we'll be checking out how health promotion and CQI connect. So that's really our biggest question that we bring, and some ideas about where to from there. And we want to hear from you, so to go into breakout rooms. We'll then have a bit of a virtual fireside chat after that, and then make plans for next steps. So I'm going to hand over to Nikki, who will give us some concrete information about this program of work.
Yep, thanks, Meg. So we're not going to spend too much time on the introductions around the CRE Stride, because many of you will have attended the previous meetings that we've been talking about the CRE Stride work, and I would encourage everybody to visit the website to listen to some of the information that our partners in the CRE have provided already. But we are, as Veronica mentioned earlier, the stream 4 of one of 4 program areas in Stride, the health promotion and prevention work. And we're in the horizontal space, but of course we feed in, so the horizontal meaning that we're wanting to expand quality improvement beyond clinical services to strengthen health promotion and prevention. But in doing so, we'll also need a lot of support and assistance with the vertical integration, knowing that involving community and strengthening health system capacity for quality improvement and health promotion will be fundamental to being able to achieve our program aims. So we've got the cross-cutting themes like the CRE stride across all our work, and really importantly, thinking more about Indigenous research methodologies, the impact evaluation, and a great analogy from Katie there with our participatory action research. And I'm thinking about riding that horse now, Katie, so that sounds great. This is what we actually said in our application with the CRE proposal, that the main aim of this program area is to build, refine and test the quality improvement tools and processes for health promotion, but particularly thinking beyond primary healthcare services specifically, and thinking, knowing that health promotion happens in so many other sectors and with other organisations and in the community, and how quality improvement can be applied to improve health promotion and cross-sectorial efforts. And so these are just our 4 aims in terms of what we hope to achieve in this research area. Identifying and describing the application of tools, thinking about indicators and investigating the potential of routine collected data. And I'm really grateful to see Cherie and Walbira here, who are really doing some work in the non-clinical indicator space. And I'm really keen to hear your contributions in this. And also thinking about implementation of quality improvement and why implementation and uptake of quality improvement and health promotion has been slower than in clinical care, and altogether wanting to co-design projects like Renee has mentioned already. So, and I think that that's right. So one of the big things about the health promotion space is that it's a relatively newcomer to the field of quality improvement, and it's not just here in Australia, but internationally. And one of the things that we've been discussing as a program is the concept of creating a community of practice, which is kind of a process for connecting and sharing experiences in quality improvement and health promotion. And I'm wondering whether, Katie, if you're able to explain what we're thinking here and how everyone in our conversations can help shape this community of practice for our program.
Yeah, sure. So today's presentation is going to be a little bit different if you've been attending some of the other STRIDE sessions. We're going to take you on a bit of a journey, but first we're going to make a little proposal here that we want you to keep in mind as you go on this journey with us. So instead of presenting research projects that we're doing within this theme, we want to propose that we use this opportunity within STRIDE to create a community of practice. So a community of practice is basically a group of people who are passionate and committed about what they do, and they want to figure out how to do it better. So we think that fits us and what we want to do in health promotion pretty well. And to some extent, STRIDE is already operating in a way that's similar to this. We call it an innovation platform. And if you want to know more about like the detailed differences between an innovation platform and what a community of practice is, there's a link at the bottom of that slide where you can read Jodi's paper about that. But in a nutshell, what we're suggesting is that we use this space in theme 4 as a bit more focused. It's a bit smaller. Maybe it's not everybody in STRIDE, but it's a people who are really interested in the issue. And we use it as a space for us to come together regularly to talk about the things that are most important to us. And in this case, it means topics related to Aboriginal and Torres Strait Islander health promotion. So maybe we decide in that community of practice that we want to put together working groups, maybe we want to write new grants, but most likely we see it as a space that we can yarn with people who share our passions, that we share stories about things that we're working on, things that we're struggling with, things that we've tried that have worked or didn't work as it relates to health promotion. We also think, referencing back to what Renee was saying earlier about this need to strengthen relationships between service providers and researchers, we think that this could be one way of doing that, because it would provide a really purposeful and tangible way for people maybe who are new to the CRE to get involved and to participate in conversations that are focused on health promotion or issues that are relevant to what they're working on. So the caveat here is that we don't have all the bits and pieces worked out yet, which is why we're doing this presentation in this way. And we want your help in thinking about that as we go through. So if you look at the bottom of your screen, you should have a little box that says chat. And as we're talking, as we're going on this journey, if you have ideas about what would be really valuable to you about a community of practice, or how you think even this might work well in terms of a structure, capture that, write a little note, because we'll be able to save all of those notes and think back on it as we move forward as a group to design what this space is actually going to look like. So I think there you go. That's a little bit of information. We'll come back to it as we go on throughout the presentation. So if you forget, we can, revisit it at the end. But basically, it's just a space for us to talk about the issues we're going to go over today in a bit more detail.
Excellent. Thank you, Katie, for that. So now we want you to imagine, and you might want to close your eyes if you're safely at your desk and nothing's going to happen. Briefly, close your eyes and imagine that you're in the middle row of a bus. You've got a while to sit and relax. It's one of those trips where there's nothing to do but just be in the moment. There's a warm breeze coming in the window and the sun's in your eyes, and it makes you shut them and you feel a bit sleepy. And you just think about those memories of traveling and thinking and traveling, and just listening as a passenger to the sounds around you. You're with people you admire and trust. They are a bit crazy, but you enjoy their company and they inspire you to think about things that you don't usually get the chance to. You love how confident they are in the vision they have for what's needed for a healthy Australia that respects its First Peoples. You look behind you and you see Uncle Black and TJ. One's a bit older than you and one's a bit younger. You might need to work out which. But you love knowing that you're there among them, among the generations, with so much to learn, so much to share, so much to listen to. Not that they say very much, but geez, they're solid. Like so many of your family, they've been through the absolute ringer in life, but nowadays they really know how to care for their health and for each other. They are amazing. They're part of our Aboriginal men's group, the same one that's in the film Mad Bastards. They were even in that film in real life. You love this film, so much so that you've had Meg Williams, who's also called Meg Bastard, from working on the health promotion kit that goes with the film. You've had her and her colleague, Jack Bullman from Mibbenbar, come to your area, show the film and facilitate their health promotion program with men's and women's groups, including together. They've got the education rights to the film. It's a classic health promotion program. But what a shame it hasn't been researched and it hasn't been taken up more. You've been thinking about how to make it the centre of a research project, to try to get some evidence about it, to then try to get some funding or something. You've seen it really motivate people to change in their own lives as well as in the community. How amazing would it be to have some outcome measures that you could pass on to other people as well and capture effectiveness, how to grow, how to get some funding others to run it. And also for them to be involved in documenting their work rather than having outside people come to do that. There's been bits done, but not in any collective, visible or structured way. And it's just such a shame, but it's ringing in your ears that you think CRE Strive might be the type of research collaboration that could help with this. So much work goes on in health promotion that we don't get to hear about, and it's going to keep being invisible, and there's going to keep being struggles unless we do put our minds together to work out what needs to change. So you wonder what Nikki and Lynette might think. They're sitting just in front of you. You know pretty well, Lenny, but you've heard heaps about her. So they've been sitting all this time chatting away, and they seem to be able to talk for hours. So you figure they might have something to say, and you pluck up the courage to ask. Nikki, I wonder what you and Lenny might think about researching health promotion, improvement in health promotion. It's kind of different to quality improvement in clinical settings. I wondered what you'd done.
Yeah, thanks, Meg. I'm just waiting for that next slide. That's it. So my journey in health promotion started a lifetime ago, literally before the birth of my first daughter, Bella, who amazingly will be 15 at the end of July. It was actually back in 2003, 2004, when the Northern Territory Health Department underwent a major structural reform and health promotion was hit really hard. The review identified that there was a lack of clear policy direction and of reasonable performance indicators that captured the provision of health promotion services. In other words, health promotion was invisible to decision makers. But as the manager of health promotion at the time, I had the privilege of hearing many stories from Aboriginal health promotion officers about the work that they were doing with their local communities, but also their frustrations that the reporting processes that were in place weren't capturing this. And I really wanted to help change some of that.
Nikki, I just wondered if I might be able to interrupt you. I just got a text from my sisters Renee and Michelle, and they could kind of hear a couple of things you were saying about health promotion and CQI. And then they let Veronica and Karen up the front know, and they reckon maybe you got something to share for everyone on the bus here. So we wondered whether we might be able to do like a poll and just find out who do we have on the bus, and do you reckon they might be all interested in hearing? So yeah, sorry to interrupt, don't mean to be rude.
That's fine. Well, I'm really curious to hear who's on the bus with us.
So everyone, if we could ask you to have a look on your screen, you should have a couple of questions now that have popped up. Thanks, Karen, for helping us with the polling. If you could please answer those questions, we'll give you a little bit of time to scroll through them.
There are
3.
Yeah, we have to scroll down.
Yeah, there are 3. Wow, we've got 83% of us already voting. Thank you, everyone, for participating.
I think it's a bit tricky, Nikki, when you've got a foot in both doors.
Yes, it is. You're right.
There was no space for that, really.
Yes, you're right.
Conversation, Jenny.
Yeah. Okay, it looks like. Okay, so we're now sharing our poll results there. Everyone should be able to see who's on the bus, where you work. Looks like we've got quite a representation this morning from research and university. And of course some important others from service provision, policies, and other. We have 37% on the bus who identify as Aboriginal and Torres Strait Islander, and we have just over half of the people on the bus understanding how CQI can be applied to improve health promotion, but we've got a significant group of us who are still a bit unsure about how it can be applied in health promotion. So it'd be really interesting if we could hear a little bit more of Nikki and Lynn yarning with us to maybe fill some of that knowledge gap.
Yeah, thanks for that, Michelle. So getting back to the NT's reform and making health promotion measurable and evidence-based, Linny, you and Bernie Girl also knew what this reform process meant for health promotion, and it was also at a time when you were on the ABCD bus with Ross Bailey and Michelle Dowden and Damien C and all those others, some of who are in the room with us or in the bus today. Wondering whether you could share with us that story about the connection that you saw between ABCD and the health promotion work that we started.
Yeah, thanks, Nikki. Can you just go back to the photo, because I just wanted to say that I do come from a health promotion background and worked in the department in that for a very long time. And Jenny J and Ali that are in there, they were very much in those early days of developing this health promotion program, and there were for the Aboriginal health promotion workforce. And so I say thanks to them for building a culture for health promotion program and the Indigenous workforce. And that lady there sitting beside me to my left there, Bernie Shields, has been around that space for a very, very long time. And in that time, this small team developed a guideline, the Public Health Bush Book. And it was a significant piece of work that we were able to do an NT-wide dissemination to help better improve the health promotion practice on the ground. It was a tool, a guideline for how do we do health promotion really well. So then through that reform phase, and yes, I got the opportunity to work on the ABCD project, and we can move on to the next slide now. Thank you, Meg. Got to the opportunity to work on the ABCD project with Ross and through Michelle Dowden. And I didn't know what CQI was about, but certainly in my experience of working there, I don't want to go into the detail for each of those steps for this CQI approach, but what I was really, really struck by to be working in a very different way, and particularly in this clinical space. And so the cycle that sits in the centre or in the middle of the ABCD health promotion was the core for our CQI activities and just go back, Meg. And what's really, really significant in this is that struck me was that it was seeing ABCD working on the ground in a systematic and structured way. And that's what I hadn't ever been involved in. The use of audit tools and protocols to guide collection of information about clinical services, and the protocol being a really, really important tool to guide that practice, that it explained the types of information we should be looking for and how do we capture that in a really, really accurate and consistent way. And so that they were really, really important tools to to this structured approach. The other tool was the systems assessment tool, and that is looking at how systems were organised in health centres and how to have those conversations with health teams about how those systems supported them in their work. The diagram, and this is where health promotion started to, the story of health promotion began. And so the diagram around the CQI model or diagram was developed by Joe Fitz Jungerai, who is in this photo, and who developed that. And that was then also formed for the way of working for health promotion. And that particular diagram was done in a poster format and presented at a conference in Alice Springs, and had won, Nikki, do you remember, we won the award for that. And so the HPCQI approach, and so our HPCQI journey started, and we had to develop tools. So the purpose of the audit tools for health promotion was developed around these 5 key areas. In this slide, you will see that there's a link to an article that gives further explanation about the audit and feedback as an evaluation approach to health promotion.
Let me know if you'd like to go back.
Yeah, going back to
the audit tool or anything.
Just going back one more slide there.
That one.
And so, like ABCD, the health promotion audit tool was based around these 5 key areas to determine how well health promotion activities align with best practice and support health promotion teams to assess and improve their practice. The tools provided a structure to collect the same information from a range of activities and projects. And the second tool was a systems assessment tool. But before we ask Nikki to talk more about this tool, the ABCD had systems assessment tool had an area for community and population-based program activities that were happening in the communities, such as nutrition, smoking, physical activity, etc. So we saw that aspect of that tool was nicely placed or fitted very nice for health promotion to work beyond the health centre settings. But some of the limitations to doing that work was with the health centre team's time and capacity and resources to do more health promotion work beyond the health centre. I'll now hand over to Nikki to talk more about the systems assessment tool.
Yeah, thanks, Lenny. So it was a really interesting process for us to be able to apply quality improvement in the ABCD approach to health promotion, because health promotion is quite a challenging area in terms of being able to capture key indicators of best practice. It doesn't necessarily apply in the same way as it does in clinical care. And I just wanted to acknowledge that Lenny and the team that we worked with at the time, the process that we went through in identifying those key 5 best practice indicators that enable services to report on health promotion at an organisational level, not necessarily at a health promotion project level. So that's how services were able to report more systematically and in a structured way about the health promotion practice that they were doing. But of course, the ABCD approach was also based on the problems in service delivery or gaps in the service delivery actually stem from the quality of systems which support it, and that in adapting those systems will actually lead to improvements in the quality of care. So the first step to improving those systems is actually to understand, I just step back, sorry, Meg. the process, the first step to improving those systems is actually to understand the components of the health system that can support the provision of good quality health promotion. So this kind of resonates with me in terms of the Northern Territory Department's remit of making it evidence-based and measurable. But if you don't have a good system to support the delivery of that care, then how are practitioners and those on the ground able to actually deliver that good quality health promotion services? So we had to adapt the ABCD systems assessment tool for use in health promotion, and that's illustrated here. Ideally, the systems assessment is done with an external facilitator, and we did a number of areas, and we've had some great QI quality improvement facilitation support in the NT in this space. And by having an external facilitator, it means it enables the sharing of perspectives from all staff at the health centre about how they see their health system functioning for their work, for being able to do their work. And having staff share their perspectives contributes to this greater and wider understanding of the strengths and weaknesses in the system. So the SAT data, or the information that's captured from the systems assessment process, actually can help contextualise the information that's come up from the health promotion audit, which creates a meaningful way and a rationale for planning action and to guide improvements in the quality of health promotion services. So I'm thinking about this a lot, and reminding myself about this improving systems for health promotion actually got me thinking to what Meg was talking about in the Mad Bastards program, and talking about those systems for documenting that invisible practice that goes on, but also developing measures to demonstrate health promotion effectiveness. So it's really important that we have this data and this information for health promotion, because that's what's really informs decision making and gets funding for this area. And it's so familiar to our experience, this lack of documentation, Lenny. And I just wanted to go to the next slide, Meg, because this is a really great story that, Lenny, I wonder whether you can remember when we arrived at that health centre to find this whiteboard, which was actually a documentation of their community health promotion story. And what we'd been doing is visiting this health centre each year, and we could see how the team had used the health promotion audit tool as a guide to document their health promotion work. And they'd thought about how they might work out in the community to deliver these healthy lifestyle education programs for their men's group. But curiously and amazingly, they also said that their clinical information systems that were available to them really had no capacity to capture that great work, that they could demonstrate the improvements that they were making to their men's health hypertensive, or reducing hypertensive amongst their men's group in the community, or the impact of the lifestyle programs that were happening in the community over time. So this then brings us back. Yep, Meg, this brings us back to the aims and how we arrived at CRE, or partly how we arrived at CRE Stride and the health promotion work, is that the key issues that we've identified for improving, or the uptake of quality improvement in health promotion and prevention, is particularly around access to reliable and timely actionable data for health promotion. We don't really have good quality information systems that enable us to record and capture health promotion's practice. The health system, organisations and the workforce capability for quality improvement and in health promotion and prevention is lacking. And there's also a really limited understanding of the application of quality improvement beyond primary healthcare. And as I said earlier, that internationally and in Australia and internationally, the concept of using quality improvement in health promotion is really new. So we hope through CRE Stride, we're going to contribute new knowledge about the value of quality improvement in strengthening coordination and collaboration for health promotion efforts across organisations and sectors. But we also hope to address that gap in those non-clinical performance indicators that are often non-existent or aren't really available to capture the impact of real-world practice, health promotion practice at a population level. So I think we're kind of getting to a point now we might have a leg stretch. Is that right, Meg?
Yeah, I think so. I think, you know, I got a bit of upset tummy, my mouse is playing up. Yeah, it's hot in here, need some fresh air. So yeah, I reckon there's a truck stop coming up. So, you know, maybe we'll go there. It's Waka Waka Country, Bam Bam Springs, if anyone's been through that way. There's so many different directions you could go in. It's known as a place to stop and get your head together and work out which way to go. And so how about we have a 10-minute break now, and then we'll come back and we'll get set up for breakout rooms and then go into those. So that means coming back at 10:31 by my clock, so 10:30 or so, and then we'll kick off after that. So yeah, probably best to have just the cheese, tomato and onion toasted. Is that right? Don't buy any seafood out this way. And can of Coke's always good for that upset stomach. The diet one.
A 0 sugar one.
That's it. So that's on my menu here.
Hi everyone. I hope you all had a good old stop there and got yourself a nice hot cuppa. Meg, that road stop's a good idea. Nice cup of coffee here, nice and hot. We've got to get back on board though. We're not quite there yet, everyone. I know everyone's been asking, are we there yet? Are we there yet? But we've got a bit of a road to travel. And we've got to watch those border restrictions. You're so right, Nikki. So let's all jump back on board this bus and keep going with our journey. A really important part of any journey is the yarning that goes on, and we've already heard some great yarning already this morning in these sessions. And what we'd like to do now is to put you all into breakout rooms for 10 minutes. And we have 3 questions that we'd like you to focus on. I'm also going to put those questions in the chat function, just so you've got them there to refer to easily. Question 1's really, why do you think CQI implementation and uptake has been slow in health promotion or slower than in other areas of primary health care? The second question, in what ways could CQI be used to make health promotion visible and deadly, as we have seen in other areas of PHC? And the last question is about our community of practice. How might our community of practice support health promotion CQI? So we've got our Deadly team as facilitators. So you're going to go into a breakout room with one of my lovely sisters, and they're going to facilitate the 10 minutes and be timekeepers. We'd really like you to add your thoughts and a few key discussion points to the chat room, please, so that we can capture your fantastic yarning. And we'd love someone from the group to just feedback maybe 3 main points from your breakout yarn when we come back together. So have fun, get to know each other, get your teeth into these 3 questions. And thanks, Karen, for helping move us into the breakout rooms now. Okay, so Karen's currently weaving magic, and you should all soon be allocated to your breakout room. Sorry, a few people didn't get time to get a cuppa, or some loo paper ran out even. That's a bit of a worry. And only prawn sandwiches being left there. That's no good. Hope we haven't missed a few people on this bus. Oh, Nikki, you got a lukewarm pie. That's no good.
Yeah, but the last time I spoke to you,
I did buy yeah, usually a little rack of, changeable.
Yeah, some of these stops you've got to really have a look at what's available. Okay, you should be able to in your breakout rooms very shortly, folks. We'll see you in 10 minutes.
you got to bring up your camera. Hmm? Bring up my camera. Your camera. Yeah. Oh. Oh no, yeah. Run away. Dixon. Thanks, on good job. You're right there. Looks like Karen's got their microphone on. Have a good time. Okay. Good job, Mum. Oh, that was a PowerPoint.
Hi, Ellen.
Hi, Karen. My power went off and I dropped out of my breakout room.
Do you know which one you were in?
I was in with Nikki.
Okay, I'll put you back in now.
Thanks.
Okay.
Yeah, the power was on me, I think it was. No? The screen.
Hi, Megan, it's Karen. Oh, you're on mute.
Sorry, I had to go
That's okay.
do something else.
Do you want me to pop you back in a room, or we've just got another 10 minutes?
No, look, I'll just wait. Yeah, I'll wait. Thanks, Karen.
Okay, well, see you soon, Megan.
Yep, thanks. Bye.
We're starting to all get back on the bus now. Thanks, Karen.
Yeah.
Oh, here we are. We're all back, I think. Back on the bus. Still a few more slow ones getting on.
I know I want to move to Megan's bit of the bus where it's
so
hot.
amazing to do. Hey, you're just so in the front. Oh yeah, it's nice and toasty here. Yeah.
I am so jealous.
I'm sleepy. Yeah, probably need that Minties game. That would have been good to do, eh? You know,
Yeah,
you've got to
that's
tear the Minty wrapper as long as you
can. That's it. Yeah. Okay, I think, have we got everyone back now? Let me see, 40 back on. I think we do.
Yeah, so.
Okay.
Yeah, a couple of people have had to go, yeah.
Okay, a couple of people have had to leave us. That's fine. Alrighty. Katie, are you back on the bus?
Yep, I'm here.
Excellent, fabulous. So thanks, folks. I hope you had a little bit of time to really explore those questions with each other in your small groups. And I think now Meg has set us up around this beautiful fire, and we're going to have a bit of a virtual fireside. And Katie and I are going to ask each of the breakout rooms to just share a couple of the key points with us. 2 or 3 key points from each group would be awesome. I know a few of you did actually type in some comments into the group chats. Thank you for that. So what we might do is start from group 4 and move our way down to group 1. So could I ask someone from group 4 to kickstart by just feeding back some of your key discussion points?
Thanks.
Do we remember who was in group 4? I don't know if I know what number I was in.
Ah, okay. That's a very good point. Okay.
Sorry, Michelle, it's Karen here. I've got the groups. In breakout room 4, we had Candace, Erica, Ines, Jody, Judy, Katie, Prabha, Mark, Rachel, Ross, and Yvonne.
It's us.
Okay, so thank you, Karen, that's really helpful. So who's going to feed back from that group for us?
It was really funny because as I was trying to get people to raise their hand to do that, everybody left the breakout room immediately. They all ditched me, and I'm, I guess, driving the bus solo. So I will give one more chance. Anyone else want to say anything? No one's going to save me.
I can read what I typed, which was just general discussion. So for question 1, there was some discussion around unlike clinical areas, there isn't necessarily really strict guidelines for best practice. So therefore, we were saying that it makes it a little bit difficult to benchmark how you're going. There was also some mentioning of health promotion historically has been quite undervalued by governments. So therefore, there hasn't been a lot of effort put into doing CQI because there's almost no purpose, because you have a funding cycle, and once you've completed your funding, that's sort of the end of the program and you move on to a new program. So there's no reason for it to be a continuing integration into the core business. Also, there are so many different things can affect your outcomes, and people were saying that this makes it really difficult to measure sometimes. Also, health promotion isn't necessarily a controlled environment like other clinical areas, which might find it a little bit easier to do CQI. Again, funding, sometimes the focus is on just running the project, and therefore there's not enough funding left or time left in looking really in depth at CQI and evaluation. So we spend a lot of time in the grassroots and running programs, and not necessarily putting enough focus on at the end of the game after you finish running the program. Also, again, funding streams or programs that don't become entrenched in core business, moving on to the next program, like I just said. Someone mentioned that health promotion is often quite an opportunistic health education, and funding doesn't always go to the grassroots of CQI and evaluation. And some people also said that the skill levels of the health promotion workers is a little bit lacking in a lot of organisations. So therefore, people are doing the health promotion work, but they're not aware of how to document what they're doing well. So there needs to be some incentive to improve health promotion workers and their skill sets. So that was our question 1. Question 2, we said that really it needs to be CQI needs to be part of the organisation's core business. So it needs to be just a standard thing that happens with all health promotion programs. CQI needs to be a part of the program and not left as an afterthought, or if we have time at the end. So it needs to be part of the actual program itself when we're doing the formative research, running the program, evaluation, and then CQI. So part of the whole program, which I thought is quite an interesting point. Some mention of disconnection between organisations and service delivery. Also, health promotion evidence-based practice is relatively new concept compared to clinical areas like medicine and medical research. So therefore, there aren't necessarily the same levels of development in the establishment of a solid evidence base. So knowing what works best and where. And the dominance of medicine and medical practice in primary health care is not necessarily the best sort of evidence for health promotion, although it's sort of put on a pinnacle. It's sort of looked at as the most important part, sort of research, but it's not necessarily what benefits health promotion at its grassroots the best. And yeah, they just said that we have a lot of work to do in what sort of evidence needs to be developed to best support health promotion best practice. And question 3, so how might a community of practice best support health promotion CQI? We said having people on the grassroots get together and discuss exactly what constitutes evidence in health promotion would be a really good start, because I think some people have what evidence we need to use to continue with our best practice. They also said that for a community of best practice, you really need somebody that's really quite dedicated to doing just that, to creating that community of support. Practically, we talked about really sharing resources and systematic reviews, the sharing of guidelines, so a lot of sharing, talking through in practical terms of what research means for service delivery, so how we can transition from the research that's done into practical application of that. Again, encouraging sharing of what's working well and what are some common challenges. I think when people face challenges, they don't realise that often other health promotion workers have come across exactly the same challenges. And if we have an opportunity to discuss those challenges, we might be able to come up with or share solutions that work well in challenging situations. Again, sharing of the stories behind the research. So often we read research, but we don't know the story why it came about. And talking about how we can use research in practice. And there was a really good discussion about mention of a potential national database of who's working in common areas so that we can connect and collaborate more easily with people who are working on common topics or common health issues.
Thanks so much, Candice. That's a fantastic recap of a really interesting discussion. We might go to Linny's group. Linny, who's going to feed back from your group, please?
Thanks, Michelle. I'm hoping Veronica might be able to help out here, and our team would be happy to contribute to that feedback process.
Thanks, Lenny. Yeah, Candice, that was a very great summary, hey, because it's really captured a lot of the discussion that we had as well. So I'll just draw out a couple of additional things that we mentioned. For question 1, we also talked about the recognition of health promotion as a discipline. So we know that in quite a few services, there may not be dedicated health promotion staff, but just an add-on to other roles, which makes it difficult then for it to become, you know, a focus of a CQI effort. We also talked about, obviously, the systematic capture of data as being essential, and probably why CQI and health promotion space hasn't been taken up so much. But in addition to capturing the data, it's also about how to tell the story. So how to translate that clinical story into a community story. So really, you know, as part of the CQI cycle, involving community all the way along, so that they are further engaged in health promotion activity. It was really good that our group had, you know, quite a number of CQI facilitators and service reps. So there were a lot of examples of some great work that is going on at the moment, such as the childhood anemia, quality improvement collaboration in the NT, the services where the Tackling Indigenous Smoking initiative is happening. So that went to then, you know, the data that is being captured locally by services, and what we can do to learn from those measures that are being captured, and perhaps potentially adaptable to other areas. So that led us then to talking about a space where this experience is captured. And Rowena mentioned her work with the RACGP in terms of developing up an online portal to capture some of this information. And it's then a good space to learn from between services what others are doing. And then there used to be a national data repository for health promotion activity that existed that doesn't anymore. But that system apparently was quite convoluted and complex and difficult to use. So whatever is set up needs to be easy for services to be able to capture that information and use that data again. What else? Is there anything else, team, that we need to touch on?
That's a great extension of what Candice presented, but also the unique points that your group raised. So thanks so much for that, Veronica. I'm mindful of time. We might really want to feedback from all groups. So could we just move to Meg's group? Meg, who's going to give some feedback from your group?
I'll just hold up the coloured notes that I took during the meeting, because so much got said. I couldn't help myself but jot down lots of ideas, and I do have like a couple of themes. Lots that's been said crosses over already, but for the question 1, there were issues about staffing, that's turnover, the skills, and also support for staff. And the issue of the difference between health promotion and clinical care was raised too, and it's really important to respect that difference and to do things that suit health promotion and how organic and unstructured it can be. And disconnects between funding and silos of government and layers came up as well that were barriers. So yeah, we've got about 25 different barriers jotted down there, but I think loosely in those themes. And then for the second question, it was really this notion, it's about cultural competence, you know, doing things well in health promotion and documenting, capturing them well is about having culturally safe that, you know, puts Aboriginal culture at the centre, honours and respects that too. So that there's underlying values between health promotion projects that could get captured because how realistic is it to have measures that are comparable across projects and across the country? We really want to honour and respect diversity. And then sources of funding. AMSANT's example of having funding from the Advanced Health Research Translation Centre. I'm sorry, I don't know the name of the group, but that's the funding that comes from the NHMRC. I think that's behind it. So it's real funding that is able to support that work. And then community of practice, yeah, powerful format, definitely have a health promotion focus and get some good governance around it with a bit of structure so that it can include a lot of people and be practical. They're my takeout messages. So
fantastic. Thanks so much, Meg. That's really, really valuable thinking and feedback from your group. Thanks so much. So last but not least, Nikki, could I ask for someone from your group to feedback a couple of points?
Yeah, I think Jenny is going to provide any additional stuff, but I'm just amazed that what everyone's bringing up just resonates so strongly with my own experience, and I'm so glad to be on this bus with everybody. But JJ, do you want to just have a quick, I don't think much to add really?
No, not really, except to say that we basically started talking about value. It was one of our major kind of discussion points. Evaluation has always been an issue in some ways, and much of evaluation has often been about how many people did the thing, whatever the thing was, and that isn't actually a particularly good measure to look at outcomes or what happened as a result of that. So with Andrew's help as the economist, of course, value is the really key point here. So what is value? Who measures it? Whose value is it? And if it's going to be from a community perspective, it needs to be Aboriginal communities who decide what the value of any program is and how that might be measured so that that suits. And it also needs to be community-led. So we need to have community participation from the beginning, and how the community measures the impact of those programs or things that happen. It needs to have a bang for the buck, and obviously we're talking here about the people that fund these programs, that bang for the buck, because there might not be a bang for the buck in terms of a community perspective, because it doesn't actually matter to them how much it costs. What they're interested in is the outcomes of the results of the program. And obviously you have short-term, medium-term, long-term kind of outcomes, because health promotion isn't something you can just do and then you get something back immediately. And how can we have a systems approach to this kind of process? And finally, just the workforce capacity building, and how important it is to have Aboriginal people doing those programs with communities and being led by communities for the particular things that are measured. And what we had thought about is, if you have a CQI process that incorporates community and is community led and driven, then you will have a much more powerful outcome as a result. Anything else, Nick?
That's awesome. Thanks, Jenny. That's such a great capture. Really, really fantastic things for our theme to run with. I'm really mindful of time, and I'm so grateful for all of your thoughts and feedback. I think unfortunately Renee was called off to attend to something during the session. So I'm going to hand back to Meg and Nikki just to do a very quick wrap up for our session. Over to you guys.
Great, thanks. Yeah, we really feel a strong sense of responsibility to each other as a team. You know, Michelle, Renee, Nikki, Katie, and myself particularly, and Lynn, thank you so much for joining us today. It's, you know, I guess on the shoulders of giants, or a saying like that, you know, we're very mindful of where we've come from, taking stock of where we are and bringing so much of your spirit and others with us forward. So very grateful for that, and never want to lose sight of the journey that we've come on. what rings in my mind for the present is this question that Renee has from Gidgee Healing. It's a very real question for her. How do health promotion and CQI connect? These are very different things. So for her in that service, really honouring and trying to be practical about how to respect health promotion in that space. And hopefully we know that we've been able to answer to that for Renee, you know, with our accountability to her in the team and on the ground level across a really large geographical area. The little picture there, you know, she's got such diversity in mind all the time in her service, and that health promotion means very different things in all of those different spaces. So we think today we've probably worn out our tires, and it is time to get off, but we've worn every item of clothing, we've looked through all our stuff, we've stuffed ourselves full of ideas, full of nourishment from each other, and yeah, pull those borders collective in a community of practice. We as a little team will take responsibility, take a bit of leadership in setting up governance, but be as inclusive as we can going along, ensuring that the wheels keep rolling. Any final words from anyone else, particularly the Lismore control room, the depot?
Thanks Megan and team. Thanks for driving the bus. Hey, it's been a great journey. I'm glad I was at the front and not at the back next to the loo, particularly in the absence of loo paper. But I think JJ really made a nice segue there, just with the final comment about community leading CQI processes. It's the way it needs to be. So it's a nice segue into next week, our final research program 1, which is about engaging community and quality improvement processes in a systematic way. So I hope you can all join us then, next Thursday, same time. Again, thank you to everyone for coming along. And Karen as well, she's the control master.
Yeah, thanks for having us today.
Thanks, everybody.
Thanks, guys.
Thank you.
Bye.
See you later.
Thank you. Awesome.
Thanks, bye. Thanks, everyone. See you later.
So this one.
Karen, will you be able to save that chat?
Hey Meg, thank you so much. That was awesome. Can you hear me?
Yeah, thanks. Yeah.
Thank you. That was so good.
Yeah. Well, will you save that chat?
I've saved it. Yeah. I'll email it to you.
Okay. Awesome. Yeah, thanks for that. I think my internet dropped out quite a bit, didn't it?
It was okay. It just slowed down a little, but it was fine. We could still
not too bad
hear what you were saying. Yeah.
Oh yeah, that's good. Oh, thanks so much for being there for us, and quite last minute, but
no.
Yeah.
God, it's a huge thing to pull together. You did an amazing job. It ran so smoothly.
Yeah, oh, that's good. Yeah, a bit glitchy, but hey, what bus ride isn't? In a way, yeah.
Were you happy with how it went?
Yeah, pretty much. I personally was thrown by the slides moving around without me controlling it. So I don't know why that happened. Yeah, I guess we didn't have time to rehearse, so yeah.
You couldn't
felt
tell.
a bit too. Oh yeah.
You couldn't
That's
tell.
good.
Yeah, it was seamless. It was
Oh,
really.
that's good. Yeah, I suppose we thought about it a lot, even if we hadn't practiced. Yeah.
You could
Thanks.
sense that you put a lot into it.
Yeah, it's a big thing to do. 2 hours, 5 people, diverse opinions. Yeah.
And particularly in this environment, you know, doing it over Zoom, I think is particularly tricky. You can't really, you know, you can't see people's facial expressions and.
Yeah, definitely. Yeah, we're all exhausted, I think. Yeah. So very much apprecited. Yeah, it went very smooth.
That was awesome.
All right, we'll see you on the other side.
Yeah, talk to you soon.
Yeah.
I'll send you this. I'll send you the chat and anything else that I've got, the polling results and things like that.
Okay, awesome. Really appreciate it. Okay, take care.
You too.
Bye.
Bye.
Bye.